Well, it's just a few minutes after 5, and I think we will get our program started. I just want to start by thanking everybody for participating. Obviously, if we had our way, we'd all be together in person. We would love to see you, but alas, the situation doesn't allow for that. So we're really pleased that you cared enough today to spend time with us and learn about Munson Healthcare's future and to get an update. We're very thankful for your giving as loyal donors. And in particular, I'd like to acknowledge our community partners who are with us today. Keeping our hospitals strong through these challenging times wouldn't be possible with the support of our communities. These in particular are the organizations who've supported us through the last year and continue to support us this year. As you may know, today we'll be presenting on the future of the healthcare system in Munson's medical response to COVID-19 with guest speakers Ed Ness and Christine Nefsey. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the little Q&A bubble at the bottom of your screen. At the end of the presentations, we'll have a Q&A session and we will address your comments at that time. So now, just get started on the program, I'd like to introduce you to our first presenter, President and CEO of Munson Healthcare, Ed Ness.
Well, thank you, Des. And thanks all of you for joining tonight, and thanks for all your support of Munson, not only this year, but throughout the years. And I really appreciate it, and I think your support going forward is even more important than it's ever been before, so thank you. I thought what I would do is talk a little bit, maybe even a broader picture of what COVID, how it's impacted the healthcare industry, what that means for us in Northern Michigan, and then what do we do about it going forward. And really what are the big themes we see coming out of this and where we need to go from here. So next slide, please. So, if you think back in history on industry, there are these sentinel events that change the way we do things. In the automotive industry, Henry Ford introduced assembly line that changed the auto industry forever. In the 90s, Amazon launched online shopping, and it has had a dramatic impact even today on how we all shop. 9/11 changed the way we travel by air and having security checks, and why do we think about travel? So the real question is, does COVID-19 change the healthcare industry? And I think it does. I think it's one of those sentinel events that even hopefully whether it's a vaccine or others, that this acute event changes, that our industry is still different. So what did we learn as an industry from the COVID crisis? Next slide, please. We in Michigan in the beginning stages were the early learners, were the center of this COVID. If you remember, now it's throughout the country, but in the beginning, we were in the top of the nation for both infections and deaths. And so we kind of were the ones that had to make this up when we went along, both as policy and as a healthcare industry. But because we were early and fast, we were one of the states that had an earlier and stricter lockdown, not only of healthcare, but of all of us as private citizens. So we had 2 times the national average reduction in elective procedures in our healthcare facilities. And we were only one of 14 states with stay-at-home orders in May. So we really, early on, felt the impact of this. Next slide, please. So how did it impact us as a healthcare? And, I think historically, hospitals and healthcare have been not the quickest industry to change and adapt. We tend to be stable and pretty thoughtful in how we change. And then the middle of March came and everything turned on its head. So first, hospitals saw a 40 to 60% drop in a non-emergency outpatient procedures. We were pretty unique to that here in Northern Michigan. Next slide, please. This is a graph that our finance team has shown. If you start on the bottom, the red line is kind of what our volume was, and the blue lines are what it was the year before. And on the bottom, in February of 19, we thought we had a really big event. We had several snowstorms. It was like 20 below, and everybody stayed home. And we had a little drop in our volume that said, boy, this really changed our business during that year. Up on top is a graph that shows what happened to our census and our volume during the COVID-19 pandemic. And you can see it's made what has happened in previous years look pale in comparison to what happened in the end of March and into April. Now that line is continuing to go back up. And as of today, it would be about 10% on average for our system below what it was. So we are seeing it rebound, but certainly the impact was dramatic. Next slide, please. The next big change was the use of virtual visits, and telehealth became a new normal. You know, as part of our strategic plan, we talked about virtual visits, but frankly, we had a 2-year implementation plan, and we were worried about, could we really adopt it that quickly? Next slide, please. But it flipped overnight. We now have had, since March, 20,000 video visits for our providers that for the most part would have been in person. We have 520 providers participating in this platform and doing virtual visits. If you would have told me that March 1st, I wouldn't have believed you. We're doing telemedicine in our COVID units for specialist consults, ICU consults for Cadillac and Grayling for their COVID unit. Again, really a quick adoption of that technology. Emergency departments in Cadillac and Grayling are offering virtual medicine, and we're launching telemedicine for our own long-term care. So, you know, things that we knew were coming, we talked about on the strategic plan, but we thought would take months, took days to implement. So that's another big change. Next slide, please. So other changes that happened throughout the state is inpatient. We had to switch around our units and how we cohort patients to accommodate COVID-19 as a system. We put those in just a few of our hospitals, but it changed our unit configuration and our staffing models. Most administrative functions began to work from home. At our peak, I think we had 1,000 workers that were working from home, which, you know, all of those would have been in an office someplace. We still have just under 700 workers working from home. And so again, a huge switch in the way we do our work. As I think you've heard in the media, traditional supply chain sources for PPE became ineffective. Most of our PPE comes from China. And so when that supply chain got disrupted, we very quickly had to scramble for other sources. And Mark DePonio and others were up all hours of the night trying to find alternative sources. And then finally, the economic health of our local communities became threatened. So, you know, we are tied to the strength of our communities. It ties to whether people have insurance, whether they feel comfortable having elective procedures. And so really in this 1 to 2 weeks, everything switched. Now, next slide, please. Out of that, I think came some positives. First, we learned that as an industry, we can change quickly. Things that we thought would take 1 to 2 years, we actually can do in 1 to 2 weeks. That's a good lesson for us going forward. I think virtual visits are here to stay. They probably drop off some, but it's predicted that 20% of physician visits will remain virtual into the future. We found that telehealth can be a real solution to providing access to our rural communities, and whether that's in our ICUs or in our clinics. We think this is a very positive outcome of, you know, the difficult times we've had. We've learned that staff can work from home. Again, we had 1,000 people working from home. Some of those will come back, but some of those may never come back, which is implicates on our real estate. You know, do we own all these offices, or can we get out of some of these things? And I think finally, on a positive, COVID-19 reinforced the role as a community hospital. I think in our small towns, we always knew that, but it reinforced how important our community hospital is to be there as a resource for these public health crises. Next slide. I think the crisis, though, did expose some of the weaknesses in our healthcare system. And this is not just Munson, it's really speaking to the state and the country. It detailed our financial dependence on procedural and outpatient volumes. When those elective procedures dropped, it had a huge financial impact on our hospitals. And I think that showed a weakness in our system where we're so dependent on those procedures that are elective. And not the underlying medical and trauma care. I think it highlighted the fragmented, underfunded nature of our public health system. In many of our communities, we have maybe one public health officer that has, lots of responsibilities. And so I think it showed how, as communities, we have to pay mind to that. It showed significant disparities in how our health systems care for the underserved in all of our communities. In Michigan, 40% of the COVID-19 deaths were from African Americans, while only 14% of the population is that. So it shows that we do have disparities in how we deliver care to our communities. And then finally, it showed how vulnerable our supply chain is. We had a great just-in-time inventory system. But when you have just-in-time inventory, it's very fragile and subject to these disruptions. So we got to address that. So what do we do about it? What did we learn both as a healthcare system and for Munson? Next slide, please. I would say that we had a strategic plan before we went into this COVID system. We had identified 6 main strategies that we thought we needed to do as a health system to thrive. To make sure that patients stayed in Northern Michigan, to use technology to better drive care, to transform how we deliver our care system to make sure our population stayed healthy, to make sure we had the information so our clinicians can make good decisions, to work with our providers as patients, and then to integrate and make sure we acted like a system rather than a collection of pieces. So I would submit that, frankly, that I would say that strategic plan that we had last year is exactly right on. But what's changed is the pace at which we have to implement that change or implement these strategies. Next slide, please. So I would submit that if we look forward, big picture, first, we're going to have to learn to thrive in an environment with decreased reimbursement and revenue. Whether or not all the electives come back, we're going to have some factors that I don't think are going away. So the state and federal government's been spending billions on aid to not only hospitals, but other parts of our economy at a time when the revenue is going to be down. So I think there's going to be significant budget deficits going forward. They have to do, I think healthcare represents 37% of some of those budgets. So either they're going to have to shift risk to providers, so we have the risk for cost, or they're going to have to decrease reimbursement, maybe both of those. So we have to work in an environment and plan for that. I think hospital volumes will remain below previous levels for some time. It's going to vary by our facilities and by department. Some will bounce back quicker than others. And even in our communities, I think communities like Charlevoix are bumping back faster than some of our others. But we have reduced physician office capabilities because of our COVID restrictions. And we have economic impact on healthcare. Some of our community members have lost jobs and maybe their private insurance. So we think there'll be a drop in those insured commercially and probably a shift to Medicaid. And then we'll continue to have supply chain shortages that'll probably impact our ability to perform certain tests and certain procedures. Next slide, please. So what else do we think strategically? I'd say that the telemedicine cat is out of the bag and is not going back. So we're going to have to make sure that we have technologies that meet the needs of our patients. They have spoken to me and they have said they want to use virtual technology to have access to care. We're going to have to respond to that and even speed up. I think our pace of change to the system will be even more significant. You know, I think back of what's happened over the last 3 months, and it kind of spins your head about all the change that's happened. I don't think that's going back to the way it is. We're going to have to adapt to make decisions quicker and to change our healthcare system to keep up with this new environment. And we're going to have to work on accelerating work to become a system. So, you know, we have been on this journey of acting like a system rather than a collection of pieces. And so whether it's clinical coordination of how we provide cardiology or orthopedic care, or system services like how do we provide IT across a single platform across our system, or pharmacy services, we're going to have to speed this up because frankly, things like our IT roadmap have to be done quicker than we earlier contemplated so that we can act like a system and better serve our community's needs. Next slide, please. So on the one hand, it's really scary with all of this change going on, and thinking about how do we survive with lower revenue and how do we act differently. But what I can tell you is not only by the way we responded as a management team and as your medical staff, I think it shows that we can be successful with these challenges. And I think we're very well positioned to serve our community for the next 100 years and really look forward to doing that with your support. So we'll come back at the end with questions, but I will now turn it over to Christine with some more specific discussion on our COVID preparedness.
All right, good evening, everybody. Thank you, Ed. I'm just going to walk through briefly sort of what we've been doing over the past couple of months. Please keep in mind this is by no means comprehensive, but just sort of an overview of how things have changed and developed and what we've done. Next slide, please. So I'll take you back to January. Remember, just getting over Christmas, settling down, it's cold and dark and snowy outside. And we start to hear about these cases of an unusual respiratory illness in China. Next slide, please. By the end of February, it had spread pretty significantly across Asia, and we were starting to see sporadic cases across Europe and the United States. Next slide. This was the end of July. So you can see here by this map that it was spread to all 188 countries and all over the world. Some places a little bit more inundated than others. Next slide, please. So for us, this was the beginning of March. This was really about when we started to see things happen locally. And you can see there what the case distribution was like. That was the beginning of March. We had about 600 cases in the United States, and there were 26 deaths. In Michigan, we had 47 people under investigation that were, and then about 88 that were being monitored. Next slide. This was the United States in the beginning of August. So in all 50 states, by that point, we had over 93,000 cases and over 150,000 deaths. Next slide. So just a quick little timeline. So March 11th was our first case in Michigan. On March 13th, Munson Healthcare stood up its System Clinical Incident Command. March 17th, we had our first cases in our region, and that was when the executive order started being implemented. On March 18th, we had our first inpatients here within the healthcare system. We implemented the week of March 22nd, telehealth, and piloted it in some of our clinics in Grayling. And by March 29th, we had launched it in all of our ambulatory employed clinics. On April 1st was when we moved from our yellow to orange pandemic level. That is around the same time where we started implementing things like universal masking, closing down entrances to our hospitals and clinics. We started really feeling, I think, the pressure of the PPE issues and supply chain issues that we were having. So we started reprocessing our masks. On April 22nd, we infused our first patient with convalescent plasma. Next slide. We continue to manage and deal with COVID-19 every day still today. This is just a snapshot for you of our Dimensional Insight tool that's on our intranet that we look at on a daily basis. Our System Clinical Incident Command has gone from meeting daily to meeting 2 times a week, but we still have pretty robust meetings and conversations and decision making. This is one of the things that we look at. So for our region, we have 1,515 cases and we've had cumulatively 55 deaths. We look at the percentage of our positives to total cases. We look at the state numbers, how long they or how much they've increased over the past 24 hours, and really try to manage and as best we can predict where we are and whether we're doing better or worse, and whether we need to go back to some of the things that we implemented when we had many more inpatients than we do now, or whether we are in the right spot to continue doing things like reopening. Next slide, please. So total for Munson Healthcare, we have tested within our walls over 21,000 patients. We've had 520 test positive. We've had 55 employees test positive. We've admitted a total of 129 patients. 100 of those were to a critical care unit, and we've had 21 patients die. Next slide, please. When this first started, we really had to take a step back. Of course, we have a disaster management plan all implemented, but every situation's unique. So we took a step back and said, okay, what do we need to do? We need to institute our disaster plan. We need to get infection control plans in place. We need to look at our policies and procedures and how this pandemic are going to impact that. We needed to ensure that we could deploy instruction in the proper use of PPE for our staff. I think this was critical. We learned this from the Ebola outbreak, that the proper wearing of PPE and the proper donning and doffing of that PPE is really essential as you start to see patients. And then we had to ensure that our patients and our potential patients in our communities' needs were met as best we could, given the situation, and especially in our case, the executive orders. Next slide. So, we needed to look at all of our staff, whether those were physicians or nurses or administrators or support staff, and that they were prepared with the right knowledge about this illness, with the right skill set to manage these patients, and the right equipment. We had to support our local population so that they had the same information. We had to stay up to date on current data and recommendations, and I can tell you that this was a huge challenge for us as the recommendations from the World Health Organization and the Center for Disease Control changed rapidly. Just think about the recommendations on wearing masks and how much that has changed since this outbreak started to today. We had to be adaptable and willing to make decisions quickly. Ed touched on that in his slides. That was something for us that we really had to work on, and I think we did a good job adjusting to that very different style. And I think, again, as Ed pointed out, it did really force us to work together much more efficiently as a system and be much more nimble and quick in our decision making and in our operationalization of those decisions. And then the other thing was how important it was to coordinate with our local health departments as well as other health related agencies. Next slide. So I mentioned earlier, we'd set up a system clinical incident command with system level key stakeholders from administration, clinical teams, planning, operations, infection prevention, all of those folks to help us process all of the information that we were getting and really bring that into our clinical response for a pandemic. We instituted infection prevention and emergency management system huddles. We created a system respiratory team. We created a new operational team to help us get these decisions that we were making out and working. We cohorted our patients at the appropriate hospitals with ICU capability. Some of you probably have heard about this, but we essentially had 3 hospitals that we felt could safely take care of COVID positive patients with both the ICU space, the physicians that had that training to take care of those patients, as well as things like negative pressure rooms and those kinds of things that were a requirement and necessary to take care of those patients safely. If you see ever Diane Mihalik and her team, give her a virtual hug, because her team, with the education and the communication that we had to provide, not only to the media, but to patients, to our communities, to our staff, to physicians, was a huge lift, coordinating that communication. And again, with the ever-changing information that we were getting, and sometimes conflicting information we were getting, that was a huge challenge. Along with that was a continual update of our Munson Healthcare website with information both for our provider and staffs, as well as our community. We continue to do daily updates at our system huddle. And then we have also continued something that was instituted relatively early on, where we've been doing employee and provider forums and provide weekly updates on where we are as a system, where we are in our communities, any new changes that come out, and that kind of thing. And then, you know, another big lift for our legal team was the response to our very frequently changing executive orders that came out. So a lot of change and a lot of change management. Next slide, please. So where are we now? We are, given that we have low percentages of testing rates, and we've had relatively low numbers of inpatient COVID patients, and that seems to be more or less steady, reopening as best we can. We are generally around 80 to 90% of where we were pre-COVID, or sometimes we look at it where we were the same time last year. And we are planning for an unknown future, which is, you know, fun and interesting and also challenging. We don't know what's going to happen as schools reopen. We continue to see cases, albeit low numbers, they are steady numbers. We obviously see hotspots around the country, and we don't have closed borders and people travel. And then we've got the flu season, which we don't know what that season's going to look like. So those are all challenges and things that could significantly impact what things look like for us as a healthcare system. We still have no vaccine, and we still have no clear treatment. So, you know, we are using remdesivir. It appears to be relatively safe and somewhat effective, but the reality is, given the situation, we haven't been able to, across the country, do really good studies and understand the effectiveness of it and when it's best to use. And there's a shortage, so it's still being allocated, and just like our supply chain and personal protective equipment, it gets routed often federally to hotspots in other areas. I mentioned earlier the convalescent plasma. We have treated a total of 22 patients. What I can tell you is that it is a safe treatment. We are now going back to look and try to measure better its efficacy on, granted, a small number, but the data that we have for now. Next slide, please. So I say we're sort of in the middle of it. We've certainly seen a surge and are prepared, although uncertain about what will happen in the future. So we continue to be in a preparatory phase so that we make sure that we can manage whatever comes around the corner, whatever that may be. So that is the end of my presentation. I thank you for your time and for joining us today. It looks like we've received a number of questions, so I will now turn it over to Des for our Q&A session.
Wonderful, thank you, Christine. We do have some questions in the queue. If you want to add to that queue, you are welcome to do so, and I'll get started right now. First, I've had a couple of questions, and Ed, you might be the one to answer this. Some of our viewers want to understand what planned capital projects have been halted and which ones are moving forward. And I think this answer would be for the whole system.
Yeah, thank you. That's so maybe back up a bit. Back in March, when this first hit, and we were really uncertain about what our financial position would be, we froze really all projects that were non-regulatory or had a direct impact on quality. So there's still things we did, but we really took a pause. What our plan to do is we now are hoping that after the first quarter of this year, so like after September, we'll have a much better projection of what our ongoing volume numbers are and what we think the new normal is. And then we're going to build that into a financial projection that gives us some guess of where we're at with our capital, what we can move forward now, and what we probably will have to pause for a bit more. So I think our priorities haven't changed. So those projects which we've been fundraising for and set a priority are still really important and hasn't changed. What is a little bit more uncertainty is the exact start date of when we'll be able to get going on those in our different communities. So that's a broad answer. I really hope to know more, by maybe October 1st, of have a better idea of what our kind of new normal is from our financial performance, and then reset the timing of starting again on the projects that we've set as high priorities.
Thank you, Ed. I have a question from Gina in Traverse City, and she's wondering about elective surgeries. She's heard that the surgery center is stopping again in a few weeks. Matt, would you like to try to answer that question for Gina, please?
Yeah, hello everyone. My name is Matt Willey. I'm the president of Munson Medical Center. Appreciate everybody's time this afternoon. Yeah, Gina, that's a very good question, and that is information that at least I have not been made aware of. So you got my mind working a little bit, so I'll do some follow-up to kind of see where we're at. But as of what I know at the present time, there should be no change to elective surgeries at the surgery center.
Thank you, Matt. And while we have you, could you answer the question about how many, it says heart-lung machines, it might be referring to ventilators that we have in Traverse City?
Yeah, so for the question about the heart pump machines, we do have 3 perfusion machines, if that's what you're referring to, and that's when we're doing open heart cases in the OR, which helps the blood circulation continues during those cases. If you're referring to ventilators, here at the medical center, I can't speak to the other hospitals, but at the medical center, we have about 26 adult ventilators. We have 11 pediatric ventilators. We also have about 24 anesthesia machines that if we ever needed to, that we would be able to use as ventilators. So pretty significant amounts, even during the peak of our COVID patients in mid-April. We had adequate supply. We were checking on a daily basis with our leadership team where we were at, making sure that we were always at the ready. So we should have sufficient ventilators if that's what the question is referring to.
Thank you. And Ed, perhaps you can help answer the question about our current status for the supply of PPE.
Yeah, so let me start out with the broad picture. It's better than it was in March and April. So we generally, I would say that, let me back up a bit. One of the things I've learned, and it is that when we think of PPE, we think of things like N95 respirators or surgical masks or face shields, kind of the ones that get a lot of publicity. What I have learned is that PPE is made up of like 35, 40 items. And what I would say is on the big items, like N95 masks and face shields and gloves, I think we're doing well. We track that every day. We have a daily huddle that gives us an update, and we are green in those categories, which means we have at least 3 to 4 weeks or more of supplies. Where I think the challenge is there's these niche items that may not get a lot of publicity, but whether it's lab supplies for testing or it's other kind of supplies that you don't think about, those are the ones I worry about. It's just because, for PPE, we could find alternative sources. We could reprocess, we could look at different vendors. There's some supplies that are single use only. And so those are the ones that we're really paying attention to now. So it was a long answer, but basically we have enough PPE really to make sure that our patients and employees are safe. And that is not the limiting factor today.
Very good. James, this question is for you. The caller would like to understand what the update is for the Manistee ED renovation.
Thank you, Des. Well, Des and Ed and I talked a week or so ago about that project, and we have decided that we will continue to move forward with that project. It is delayed. The start date would be about this time next year, probably, or mid-September, probably, when we would start the actual physical renovation of the ER. So that gives us more time to talk to our donors and see what else we can manage to raise. We've done a nice job, I think, Des. I think $640,000 so far has been raised for that project. And when COVID hit, we were still raising money. I sent some cards out today, as a matter of fact, to donors who just gave some more money to that project. So it is still on the books. We have taken a little hiatus, but around this time next year, we should start the project.
Thanks, James. David has a question. Is there anything we can do to help improve your testing or treatment capacity? And Christine or Ed? Christine?
I can go ahead and start, and then Ed can either fill in or correct me. We just purchased 12 new machines so that we'll add the capacity to all of our hospitals around the system to be able to do testing. I think the supply chain issue that many of us have mentioned still continues to be a real issue for us, and we can't really predict what it's going to be. So whether it's the swabs to do the tests or the reagent to do the tests, that continues to be a challenge. So we have answered that challenge by really spreading out what we use to do the testing. So we use Spectrum right now, we use Mayo, we have a platform called Cepheid, and then we've got a platform that we just started called Abbott. So I think that we've responded well. The demand continues to increase, and we continue to adjust as best we can. But other than staying safe and not requiring the need to get a test, that's probably the best way you could help us at this point.
Yeah, I think that's well said. I know that some of that equipment was purchased with the support of donors, that Abbott equipment, in some of our communities. And so you as donors had a direct impact. I would say, frankly, in hindsight, if we hadn't bought those Abbott pieces of lab equipment, I really would be worried about our patient or in-house testing. So there was a direct way through your support, we were able to buy these Abbott testing pieces of equipment. Thank you.
And I'll just add to that. So when the COVID crisis started, the foundation became the call center for everyone in the region who wanted to do something to help. And the community, so as Munson Healthcare was starting to respond and mobilize, the communities were doing that as well. So we went from a volume of 150, 100 calls a week to more than 1,000 calls and emails every week at the foundation. And that was just people who were interested in doing whatever needed to be done. It was overwhelming and it was wonderful all at the same time. And so we had a supply of different companies who provided clean N95 masks and PPE for us. So when we could use that, we did. We had communities who took very good care of our frontline staff with meals and all kinds of notes of gratitude, which we really appreciated. And then we asked for donations. So really one of the best ways that you helped us is by donating. So Ed talks about the PPE shortage, and what happened overnight is the cost of an N95 mask went from 40 cents a piece to about $8.50 a piece. And so Supplies that would have cost us about $150,000 previously were now costing us far more than $1 million. And it was at that point that we really felt that we needed the support of our community. So we put a community outreach letter out in May, and we had an amazing response. We've raised $1.5 million to go towards our COVID response efforts. We asked for it to not be specific for a piece of equipment, but rather for the whole response, because I think what you've heard over and over is we had to be nimble. And what we thought we were doing one day had to be changed the next day. And that funding has been very helpful in allowing us to buy that equipment. So when new equipment came up and we wanted to purchase that equipment, you need to make very fast decisions, because people all over the country, all over the world, were trying to buy the same equipment. So when there was an opportunity, we were able to really purchase quickly, and a lot of that is because of the support of the people on this call and others. So it was a pretty amazing response. Thank you for that. A question from Glenn, and this will start from Ed, but I have a feeling that James and Peter might have want to add to the answer to this question. It's, did hospitals in the system that did not treat COVID patients have less difficulties with bottom line than the 3 that were treating COVID? So that's the question.
I frankly think I'll broaden this even behind Munson, the financial impact to hospitals frankly had very little to do with how many COVID patients they saw. So, by far the impact to hospitals in our system throughout the state was not so much the treating of the COVID patients, it was the decrease in elective and non-emergent procedures. I would say that impacted our smaller hospitals even greater than Munson Medical Center, Traverse City. And that wasn't because Medical Center was treating COVID or not. It's because in the smaller hospitals, a greater percentage of revenue and bottom line is tied to outpatient procedures, where at a place like Munson Medical Center does open heart surgery and neurosurgery, and some of those things, some of which got limited, but some of it continued because they were urgent. So it had less to do with COVID or not COVID, and I think more to do with the dependence on outpatient and elective as their part of business. I don't know, James, if you had any.
I agree entirely, Ed. That's absolutely the way it was in the South Region hospitals. Cadillac was taking inpatient COVID patients, but it didn't benefit them to do it. We all had to shut down our outpatient services. Paul Oliver was still taking or caring for long-term care patients. So that book of business didn't really change. But I don't know the exact number in Cadillac. It's not much different than Manistee. In Manistee, 87% of all revenue is outpatient revenue. So I think Cadillac's pretty close to that. So when you shut down your outpatient business, it's very harmful.
Okay. A question from Pat, and I think that this would be a question starting to be answered by Matt, and Ed might want to jump in afterwards. But Matt, as we realign services to meet less demand, what impact do you think it'll have on the size of your workforce? And do you anticipate decreasing positions in Traverse City?
Yeah, that's a very good question. It's something that we are thinking through. As Ed mentioned, when we had fewer elective cases throughout the spring months, we did furlough a lot of our staff, and we've been in the process of bringing back most of them. We have made some staffing adjustments because it has been shared that we don't necessarily anticipate that our previous volumes are going to be what they were bound to in the months ahead. So something we're always looking at. If there are ever any staffing adjustments, one of the things that we've been working with the team on is there other positions that are currently open within the system of which people could potentially go into. And so that is something where some of those that have been impacted recently have had a chance to remain in the organization in a different capacity. So we're always looking at those options as well.
Yeah, I don't have too much. Well, the one thing I would say is this is the most uncertain financial planning in my career. Because usually I can tell pretty close what our volume is going to be, what our workforce needs are going to be for the upcoming year, and we may miss it by a percentage or something, but we get pretty dang close. How fast our volume comes back, what our future staffing needs are going to be, I think is really uncertain. And so what we're doing, we used to do a budget and a financial plan a year at a time, right? And for July 1st, we would do an annual budget and it would talk about our staffing and our capital and everything else. We're now doing it quarter by quarter. And the reason is so that not only can we adjust our operations, but we can make sure that we're adding back staff and adding staff as volumes come back in those areas that come back, but yet being flexible. So, you know, we frankly are probably bouncing back a little faster than I thought we were going to on our volume, not universally, but some of those areas, that's good. And so we pretty rapidly have brought back staff in those areas. And so I wish I could give you an exact answer of what it would look like a year from now. I can't because there's too many unknowns, but we will just keep watching it on a quarterly basis to make adjustments. And hopefully, again, the volume and our life gets back to normal quicker than we thought, and we can kind of get back to that new state of reality.
Thanks, Ed. Christine, a few questions coming your way next. How available is convalescent plasma, and will the availability increase?
Let's just start with that one. So, you know, that is still in the testing phase. So it's not been an approved treatment yet. So it's still, you know, being done under grants and, you know, as a testing type of thing. So I think as they start to get more people who are doing the convalescent plasma studies and they get the safety and efficacy results, if they're good, we will see an expansion of that. Of course, it also depends on people being willing to donate their plasma after they know that they've had COVID-19 as well.
And as a follow-up question, are we accepting plasma donations from recovered patients?
If you go on our website, so we are working with a company called Versity who is doing all of that collection and managing that study. So we aren't doing it, I mean, we are at Munson Medical Center and we are participating in that study, but it's not us who is doing the studies, if that makes sense.
And the next question also for you, Christine. How many people who went on ventilators were able to come off of them alive?
You know, I don't have that data. I know that they are collecting some of it through our ICU, but I don't have that data at the top of my head.
Another similar question, maybe. There was an article in the Wall Street Journal today arguing the speed of testing over accuracy based on a saliva on a litmus-like strip for immediate results. Do you have any comments on that, Christine?
Well, you know, I think part of the challenge in this pandemic has been around testing. You know, what we know is that the RNA PCR test is the most accurate test, and that tells you whether you have actual live virus on hand. There are a lot of other tests in there, antibody tests, antigen tests, and unfortunately, because of the, you know, the speed where people were trying to bring testing out, many of those tests that were brought out were not accurate. So I don't know this particular one. I know there has been a lot of work because the original test for the PCR was somewhat aggressive, where you had to go back and do a nasopharyngeal swab, and you know, it's uncomfortable and it kind of hurts sometimes. And so people are looking and doing some studies to see, you know, could you just do a nasal swab in the front of the nose and then, you know, the salivary swabs and that kind of thing. But I have certainly heard that those tests are being looked at, but I couldn't speak to the efficacy the accuracy on the sensitivity or specificity of those tests at this point. I'm certainly hopeful that it would be really nice as school starts if we could have a quick, rapid, less aggressive test.
A question for Peter. Paul Oliver, outpatient volumes, have they returned to previous levels?
Yeah, we started to see the levels pick back up towards the end of May and then into June. So a little bit of it was difficult to understand if we were seeing pent-up demand and people coming in for tests that they had held off. Diagnostic tests such as x-rays, labs, those went actually over prior year numbers, but I think again that was pent-up demand. Rehab has been a little slow to return. Here in Cadillac, we're actually seeing a return to normalcy with procedures and surgical volumes. Similar things with lab and radiology are increasing. Urgent care is a little bit lower than what we've historically seen, and we're trying to really understand if maybe that's more the virtual component or maybe if it's just a change in patterns.
Same thing in Manistee. All of our volumes are looking good, except our walk-in clinic is still down. Probably doing a third of what volume we were doing prior to. Our ER volume is down from last year, but tracking better than what we had predicted. But most of we did as many surgeries in July this year as we did last July.
That's good news. Matt, do you remember the cost of the Avid equipment, the testing equipment we just purchased?
I do. So as a system, we purchased 12 of them, and each one was $3,000. So a total investment of $36,000. Because of the number of patients coming through some of our sites, as an example, the medical center will have 2 of those 12, and Cadillac will have 2. But again, very modest, minimal investment to have that capability, more in-house testing.
And one final question for Christine. Do you know where the closest antigen testing site is?
The antigen testing site, I don't. We have chosen not to do the antigen testing. The antigen testing accuracy was probably one of the ones that was the most varied and all over the place. So we are doing the antibody test, and we do the PCR test, but as of now, the antigen test is not one of the ones we're doing.
Thank you. So that wraps up our Q&A pretty much on time. So I just want to give a big thank you to Ed Ness and Christine Nefsey, Matt Willey, Peter Marinoff, and James Barker for answering the questions that we had and for your wonderful presentations. I think it was very informative. I'm pleased when I know we can answer all the questions that we've received. I want to thank all of the participants, knowing that this isn't usually the way we would want to get together, and usually is not the way we want to say thank you to you. But having the ability for us to report back to you is really important to us, and I hope you found it of value to you. We are very grateful for the giving of everyone who's participated. And if you know of friends and neighbors who weren't able to join today, we are doing a repeat of this very event next week. So please encourage your friends to attend at that time. We're happy to answer questions. We're happy to be here and available for you, both for your healthcare needs, but also to help answer your questions as community members. Thank you for your time and have a wonderful evening.
Thanks, everybody.
Thank you, everyone.